Dear colleagues, as usual, I will use some of my time to give you some information. It has been decided that the third Balkan Rhino Forum is going to be in 2021 in Athens. So I'm already inviting you all to come join us and be with us in Athens 2021. That is one thing. The other thing is when we were preparing this second Balkan Rhino Forum, I was going through the topics, and as usual, there was nothing about olfaction. So that is why I decided to talk a little bit about olfaction. Professor Fawkins mentioned the beautiful position paper published in Rhinology, and it's free for downloading on the website of Rhinology, and I recommend this position paper to all of you. So this is one little piece of the problem of olfaction. In neurodegenerative diseases, there is a link between neurological diseases and olfactory dysfunction. There have been extensive investigations that have confirmed the association between neurodegenerative disease and olfactory impairment and demonstrated the high diagnostic significance of this link. However, olfactory dysfunction is usually neglected by physicians at large. It is commonly seen as two most important neurodegenerative conditions, which is Parkinson's disease and Alzheimer's disease. But also, you will find data about olfactory dysfunction in all these entities, starting from epilepsy to stroke and many more that are not here on this list, so neurological diseases. There is a considerable variation in the prevalence and magnitude of olfactory dysfunction among neurodegenerative disease. So it is very severe in Alzheimer's, Parkinson's, and Parkinson dementia complex of Guam, but in other disorders is more moderate. In general, 5% of people are anosmic. The loss of olfactory function actually, as you know, increases with age. Above 50, about a quarter of us have presbyosmia. There is a special characteristic of the olfactory receptor neurons is that they continuously renew themselves from the basal cells, and this regeneration capacity diminishes with increasing age. The cerebral processing of odors involves, among other structures, the limbic system, amygdala, hippocampus, cerebellum, and insula, and orbitofrontal cortex as very important structure. Diagnostics in olfactory dysfunction is, as usual, starts with history, which should be really detailed in all these patients, meaning onset, course, nature of the impairment, previous illnesses, medications, etc., ENT examination, endoscopy of the nose to exclude the sinonasal disease, then orthonasal and, if possible, retronasal olfactometry, magnetic resonance imaging of the endocranium to exclude, for example, a tumor, and olfactory system to examine olfactory system, and if possible, but it is possible only in few centers in Europe, which is hemosensory event-related potentials. And in the end, a referral to a neurologist, which we usually forget, particularly in the cases of idiopathic olfactory dysfunction. Just a reminder that many patients who have olfactory dysfunction will first come to you complaining that their sense of taste is blunted, so don't forget that. There are really simple screening tests for olfaction, which just distinguish between healthy and sick. You can get useful and readily understandable results in minutes, and they are really easy to apply. In Europe and in my clinic, we use sniffing sticks system, which has a screening test and more extensive test, which is called TDI. I will show you. This is the screening test of 12 pencils, and it can be used in children 7 years and above. And this is an extended test, which is a TDI score, identification, discrimination, and threshold. Actually, if only the ability to discriminate between odors is affected, we can suspect central nervous impairment, and isolated shifting of the olfactory threshold tends to indicate peripheral damage. In the United States, what you will see, they usually use the UPSIT, which is University of Pennsylvania Smell Identification Test. When we do an MR, we should check on the nasal olfactory mucosa, measure the olfactory bulb volume, the sulcus depth, and the presence of the olfactory tract. So this is the normal findings of the olfactory bulb volume, the depth of the olfactory sulcus, very important for the congenital anosmias, and this is one of our patients with normal finding. So if you refer a patient to a neurologist, he should do a full cranial nerve and peripheral nervous system examination and tests of memory and cognition. Olfactory dysfunction is an early symptom of neurodegenerative disease. It's an early warning of the most frequent neurodegenerative disease, which I've said are idiopathic Parkinson's disease and Alzheimer's. Many other neurodegenerative diseases have olfactory dysfunction, but not usually as an early symptom. The focus today is on the potential for olfaction to be used as a biomarker for early or differential diagnosis and prognosis of neurodegenerative diseases. Olfactory dysfunction in AD and PD is present in 85 to 90% of patients in the early stages, but most of the patients are actually unaware of their olfactory loss. Idiopathic Parkinson's disease has tremor, rigidity, and akinesia, but also olfactory dysfunction in 95% of patients. They will describe a gradual onset of olfactory dysfunction. They do not report parosmia and are unlikely to see any improvement over time. So you have severe hyposmia or anosmia in most patients, and also ageusia. So in patients found to have normal olfactory function, the diagnosis of idiopathic Parkinson's disease should be reconfirmed or other diagnosis considered. The sense of smell deteriorates very slowly, so it often goes unnoticed. And it is very important to remember this. It precedes the motor symptoms approximately 4 to 6 years in idiopathic Parkinson's. So we should consider this disease in at least some cases of idiopathic olfactory dysfunction, particularly a specific group having REM sleep behavior disorder or depression. Considering relatives of patients with idiopathic Parkinson's, this study took 361 relatives, out of which 40 had hyposmia, and they were diagnosed as having IPD 2 years later. So it's really important to see what is happening with the sense of smell. Normal olfaction, together with normal cognition at baseline in patients with idiopathic Parkinson's disease, predict a benign cognitive course up to 10 years after diagnosis. So, simple smell test may contribute to identify patients at risk of accelerated decline in global cognition, verbal memory, and processing speed within the first 7 years from diagnosis of Parkinson's disease. There's other Parkinsonian syndromes, and so far the American Academy of Neurology recommends including tests of olfaction in the diagnosis of idiopathic Parkinson's disease, although so far only the distinction of this disease from progressive supranuclear ophthalmoplegia and corticobasal degeneration is viewed as reliable. There's also other Parkinsonian syndromes like vascular, like what you often see, that's neuroleptic drug-induced Parkinsonian syndrome, and there is close correlation between the degree of hyposmia and the severity of motor symptoms. There's also one on the basis of Wilson's disease. So hyposmia is more often present and typically more severe in patients that have Parkinson's disease than other Parkinsonian syndromes. So it's a potentially useful biomarker for this disease. Then there's Alzheimer's. The olfactory bulb is one of the first areas of the brain to sustain damage in the Alzheimer's. Brain areas that receive information from the OB, such as entorhinal cortex, are also affected early in the disease. So impaired ability to recognize odors often occurs in people with early stage Alzheimer's before memory symptoms are noticed. The latest research indicates that even olfactory nerve undergoes early and sequential morphological and signaling alterations that correlate with the development of dementia. Olfactory dysfunction in Alzheimer's is associated with disease progression, can be helpful in the differential diagnosis of major depression, and may have clinical value as an early diagnostic marker in predicting incident and high-risk individuals. Odor identification or identification deficit are an early feature of Alzheimer's, preceding more frank impairment in odor detection, and has been shown to predict progression from mild cognitive impairment to Alzheimer's dementia, particularly when combined with other clinical assessments like imaging and other markers. So inability to identify odors correlates with memory decline. In contrast to IPD, so idiopathic Parkinson's, a clear correlation has been demonstrated between the severity of AD symptoms and olfactory performance. Since the Alzheimer's dementia pathologic process likely begins more than a decade before emergence of symptoms, a simple, accurate, cost-effective screening tool for preclinical disease is desirable, particularly for treatment and prevention trial designs. Now there's also Huntington's disease. These patients have moderate hyposmia. The olfactory changes begin at the same time as the motor and cognitive symptoms, but some found it in asymptomatic carriers of the Huntington disease gene. There's also heteroataxias, there's also motor neuron diseases like Creutzfeldt-Jakob's disease, etc., etc. What are our treatment options in olfactory dysfunction of neurodegenerative origin? Medicinal treatment of idiopathic Parkinson's seems to have no effect on the olfactory dysfunction. Deep brain stimulation in the subthalamic nucleus shows some positive effect on some aspects of olfactory processing. A promising approach is olfactory training. In view of the potential consequences of olfactory dysfunction, so failing to notice that foodstuffs are spoiled, patients with such diseases must be informed about the accompanying olfactory symptoms. And just briefly, two studies. One, this is the first study reporting on age-specific associations of olfactory function and cognitive performance in the general population. It was done in Germany on large number of participants, 2,640. Participants aged 65 to 74 with olfactory dysfunction showed impaired cognitive performance, and the effect was more present in women. Assessing olfactory function may be an appropriate marker to detect persons at risk of cognitive decline, especially in this age group between 65 and 74. And this is the other study that was performed in the United States, trying to use the UPSIT as a potential screening tool. And they found that those who had odor impairment were more than 3 times as likely to have memory decline a few months later compared to those who didn't. So to conclude, olfactory dysfunction is common in later life, but is also an early warning or neurodegenerative disease. There is a potential for olfaction as a biomarker for early or differential diagnosis and prognosis of neurodegenerative diseases. Thank you for your attention.
Nice presentation. Do you have any questions for the audience? Professor Livia Kalogira.
Thank you, Ljiljana. You always have a very nice educational approach. First question is there a pattern in the sniffing sticks response difference between Alzheimer and Parkinson?
No.
In the pattern of it's like dementia.
I will answer right away. There is no test that can distinguish between early Alzheimer's and early Parkinson's disease.
And the other thing is that they usually say that women preserve smell longer than male, but you had a paper that said, but is it regarding only those who will go to dementia?
Yes,
yeah.
Yes, okay. The memory decline, yes. Thank you for your questions.
Ljiljana, I would like to ask you if olfactory training could actually slow down the progression of degenerative disease. The progression of dementia. Could the olfactory training not only preserve smell, but also slow down the disease progression?
No, it will not slow down the disease progression. It has nothing to do with that. It was just about olfactory dysfunction in neurodegenerative disease. But thank you for the question, because I would like to repeat once again what is olfactory training. That is when people take 4 substances twice a day and smell them for 10 seconds for at least 12 weeks. Now it's rose, eucalyptus, lemon, and cloves. And there is a company in Germany that is producing 4 sticks, which you can buy. It costs like 40-something or 50-something euros. So you can do olfactory training. Olfactory training helps in so many diseases, and wherever you have, for example, post-infectious, post-traumatic, idiopathic, so it helps in all these indications as well as in neurodegenerative disease.